So I was actually at a workshop for the podiatry folks, all the podiatry staff of the VA, and asked them if somebody could come and do one on podiatry. And actually, since I've been in this job, I hadn't seen a podiatry lecture, but I was reminded that we have had them before. But Dr. Alayon is volunteered that very day, Monday, to present to y'all. So here he is, and I appreciate it. He's just fresh out of surgery. And I'll let you take over.
Well, she said she asked me Monday to give a presentation, so I was going to give something just on general podiatry, but I figured based on the people that are here, I geared it more to non-healing wounds or ulcers. It's something that we all see in the hospital. It's something that we see in clinics. It's more of a kind of an overview of what, as podiatry, we look for, and as what we would like. It's at the last one, the only PowerPoint. What we look for, and how we try to evaluate a wound. There's a lot of things that can complicate wounds, from simple just misdiagnosis to just it being complicated.
That is so cool. Where is that?
I don't know.
It's
I
from the
just got this picture, and
it's from the TV show Lost.
There you go. Yeah, it's from the TV show Lost.
I think it's real. Go ahead.
So, just tap it. So basically, as I mentioned, I mean, there's a huge burden on non-healing ulcers, not just from us as physicians, but patients as well. And we see throughout the years, I actually did my residency here at UTHSCSA Center, and the 3 years that I spent here, you definitely see what it does to a patient. But as you leave, there's a different parameters in the sense of the patient population that you get. In the outside and more private practice, patients are a little bit more controlled that you actually get contact with, but still the same burdens apply to them as well as they progress in their disease. And there's by far the biggest one that I see from a burden perspective is family. If the family's involved in the assessment and the help and things, it makes everything so much easier in healing a wound. If they're in there and putting forth, they're there at appointments, they're there at bedside when they're in the hospital, my God, how much easier it makes to treat that patient. And then just quality of life. The last thing, as much as some of these patients, you like to see them every so often because they're fun to meet, the last thing you want to do is make them come on a weekly basis, because on some cases it does. It's a weekly basis that you're seeing patients. And then last, from a physician perspective, it's just taxing. I mean, it's just tough to put these patients in your clinic, because it's not a 5 or 10 minute, visit. It becomes a 20-minute. It becomes a social visit. It becomes debridement at clinic. So it changes a lot, and then it's a long thing. It's a long course. I mean, most ulcers, you're looking at 30 to 60 days for them to heal if everything goes well, which it never does. And then lastly is economic. I mean, we've seen the economics burden that has been applied. I mean, just a single ulcer costs about $8,000. You start adding infection to it. You start adding major amputations. The cost just skyrockets. And that's why the last thing is wound care market. That's why we see so much money going into the wound care market. Every day you turn around and there's somebody else coming into our clinic going, I have this product, and you're like, okay, what happened to the last product that I thought was working pretty well? There's just tons of creams, enzymatic debriders, dressings. Now the big thing is the honey dressings that they're saying, which is kind of odd. I mean, I actually was fortunate enough to go to Saudi Arabia and work there for a year. And not in a military sense. It was more, I went to a private practice, a private hospital that was affiliated to the Cleveland Clinic. And it's amazing the difference that you see from a wound care perspective here to there. When I left here, honey was not even a topic. I went there the first day, they're like, so do you use honey? I'm like, honey? Why would I put honey on a wound? But, unfortunately, Europe, they are allowed to use products that probably won't even touch for years, just because of the FDA approval. They get to play with it, and, use it. Some are good, some are not. It just depends. So these numbers, if you can see, haven't changed drastically.
Yes.
In the last 30 years. I mean, these are numbers that every year it's about the same. 80,000 amputations per year in the U.S. Approximately 50% of amputation develop ulcers to the contralateral limb. And the contralateral limb in 3 to 5 years, it's 58% that they lose they get some type of amputation. So that's a concern. Anytime we do an amputation, what's the biggest risk? Something's going to happen to the other side. Treatment, preventative, it's huge that we need to keep track of. So where do we start? That's the hardest thing. You get these ulcers. Well, what do I do from here? What are my steps? And the goals that we want to do is to be able to evaluate the ulcer, obviously. Identify more comorbidities that might affect in the healing process, whether it's nutritional, whether it's hypoxia, whether it's offloading, and then have a adequate treatment plan. And by far the most important, and the one that we always forget, and even us as podiatrists, we forget, we lecture on it, we educate, but that's the biggest one, educating the patient, making them understand where they're at in the spectrum of disease. And that's how we would like to do it. Are they at low, moderate, high, severe? They need to understand, and that's the hardest part, to get patients to understand that. And from the population that I've seen here, it was a younger Hispanic population. Being Hispanic, it was just a very tough thing to tell a young Hispanic male, look, you might lose your leg. It's not going to happen to me. I'm Superman. It's not going to happen to me. Yeah, I know my friend lost a leg, but it's not going to happen to me. I'm not going to have this. 2 weeks later, sure enough, something happens, and they're like, oh yeah, but then it's too late. So how do you convince somebody? And there's many different ways. We can quote unquote use kind of a scare tactic of, look, this is what's going to happen. If you don't do this, this is what's going to happen. Or you kind of do different methods. It's whatever works for you. So based on that, so where do we lose this out? And the biggest part is the initial exam. We're just not adequately evaluating the ulcer. If you can see on this, and this is in 1996, but still the same, all these things still happen. And this happens even when podiatrists are getting called. So it's not, we can't just say, oh, it's the podiatrist, or, but people are just not evaluating well. They're like, oh, it's an ulcer, and they just move on. They just, obviously it's not the biggest thing of concern, but it's there. Whoa. Sorry. And some of the things is just not describing the wound, not checking for pedal pulses, not checking to see if they have sensation, not getting x-rays. Little simple things that, you would think, especially at this level when you're in education, you always do, but people don't do. And they don't do it over and over. So what's adequate evaluation? And you can see these studies, 57% get foot exams. That's a very low number. 30% never saw a podiatrist, never got seen, never was sent to a podiatrist. And there are podiatrists and there's physicians in the community that don't want to see somebody that there's nothing wrong with them. But from the experience that I've had just being out, you want to catch them early. Yes, we love that, to do something, but if you catch them early, you can prevent so much stuff if you can get them on shoes and offloading, educate them. But, it's just a matter of getting them to see somebody that's comfortable with the diabetic patient. So successful management is dependent on accurate assessment, management of the underlying cause, and appropriate care of that ulcer or wound. And this is something very significant. Major foot ulcers are just from a small trauma, being neuropathic, little things, wearing the wrong shoes, one day wearing tight shoes, not, little things that they don't think of. They're like, oh, well, I've been wearing this size forever. Why should I get size when I go get shoes? Well, that's, important to do. So this is what I call the critical triad. These are the things that is going to make something happen to the foot, at least from a podiatry perspective. They're going to have neuropathy or loss of sensation, and they're going to have some type of deformity, whether it's a hammer toe, a bunion, anything like that can cause, and then trauma. And that could be shoes, it can be bumping it can be multiple things. And as you see, 65% of diabetic foot ulcers have all three present. So it's there. So what's the at-risk patient? Obviously, how long they've been diabetic. Do they have peripheral vascular disease? Do they have neuropathy? Do they have a history of prior ulcerations? Right there, that gives, they're at 12% higher risk of getting another amputation. Hygiene, it's significant if they just don't check their feet every day, and that's where family comes along. Is somebody there? If they're not able to look at their feet, is somebody able to look at their feet? Is somebody checking on their, on a daily basis? Is somebody looking, even when they put on their shoes? I always tell my patients, check your shoes every time you put them on, before you put them on. Who knows, what might, get in there. We had a patient, actually when I was a resident, come in and he goes, oh, I don't walk barefooted. He just had a hallux amputation. I don't walk barefooted. I'm always in shoes. We're like, really? Do you know what's on the bottom of your foot? He's like, no, there's nothing. And there was a beer bottle cap on the bottom of the shoe. So what does that create? It creates another ulcer. So, but he's, we always tell patients, wear shoes at all times. I wear shoes every time I leave the house. They're like, okay, well, how often do you leave the house? Well, not very often. You're at my home all day. Well, that's when you need to wear them. I mean, no matter how clean your house is, it's more important to wear the shoes then than when you're going to a doctor's appointment, in essence, because it's just like when you get in a car wreck. Most of the car wrecks are a mile, 2 miles from home. Why? Because that's the most that you drive. That little span is the area that you drive the most. So what are contributing factors? Obviously calluses, swelling. Swelling is a huge contributing factor in not allowing a wound to heal, because it causes hypoxia from the wound, and peripheral vascular disease. So we have to evaluate the wound environment. We also have to evaluate neuropathy. Do they have neuropathy? How extensive is their neuropathy? And then vascular status. One of the things that a lot of my patients will come in and they're like, oh, I can feel you touch, it tickles when you touch my feet. Well, that doesn't mean that they're not neuropathic. That's a whole different, spectrum of neuropathy. We check it. We do, obviously the easiest is the Semmes-Weinstein monofilament, because you can carry it with you, you can do it at the hospital, you can check it, but by the time they're grossly absent with that, they're pretty far gone in neuropathy. So we do the biothesiometer, where we actually do vibratory, because that's usually the first sensation that a diabetic loses. So we'll do a biothesiometer, we'll check their vibration to see where they're at in that spectrum. So anything under 25 volts in that biothesiometer, we're fine. Anything higher than that they can't feel, they have to go higher than 25, we've pretty much already put them in that neuropathic realm. So other things that you can do the tuning fork temperature, NCSs, you can always get those. And balance proprioception, they're going to lose their proprioception. That's why most diabetics, and I'm sure you're more than well aware that, their gait gets wider and their strides get shorter. And that's because they're losing that proprioception. They need more than one sensation. They're losing that sense of feel. The best way that I can explain to a patient what neuropathy feels like is if they put their hand next to mine and then they just rub their fingers like that, it's that sensation. If it's almost like an out-of-body experience, they can they know that you're touching, but it doesn't feel right. So that's the best way that I found to explain it. They're like, yeah, that's exactly what it feels. Because most patients will come in, they're like, I feel like I'm walking with bricks on my feet. I feel like I'm walking on cardboard. I have ants crawling on my feet. It hurts when the sheets are placed on my legs when I go to sleep. So, little things like that you need to make them aware of. Vascular is probably the most important out of all the triad. I mean, that's what, as much as we've kind of pushed for the longest time neuropathy. We need to know, are they neuropathic? But for something to heal, it's all based on vascular. So whether they're neuropathic or not, if they don't have blood flow, there's nothing that we can do. So most of those patients are like, well, does this mean, if I'm neuropathic, does this mean I'm going to lose my leg? No, but you're at risk, and you're further at risk if you are vascularly compromised. What tests we do? We obviously clinically we do pedal pulses, whether and if we have to, we'll Doppler them if we can't feel them. Cap fill time. We do transcutaneous pressures, and that's usually just to see what the perfusion at the level of the ulcer or the wound is. Non-invasives, we send out a lot of patients for non-invasives and just to get a vascular workup on them, and especially if they're complaining of even rest pain or intermittent claudication. Well, what other things, cause this, peripheral vascular disease or vascular compromise? Obviously, poor cardiac output, diabetes, tobacco, chronic infection, and anemia. And we can see that cardiovascular disease plays a big role. I mean, we all know that in diabetes, it's huge with angina, with stroke, and also with peripheral. Because it's so, most of my patients, I start thinking if they've had an MI or if they have a history of CAD, I'm already thinking, okay, they already have some vascular compromise. Whether they have palpable pulses or not, there's compromise there. We all know that this is the 6th leading cause of death in the U.S. I mean, it's significant. So like I said, this is the biggest one that what causes that mortality rate, the increased mortality if they don't have the vascular, good vascular flow. The one thing that's been, very well in the last 8 to 10 years is that the new beginning of physicians, whether it's cardiologists, interventional radiologists, or vascular surgeons, they're doing a lot of angioplasties to the lower extremity, where when I was in residency, that didn't exist. I mean, it was always a bypass. No bypass, it's not going to heal. Now we're able to treat that high-risk patient that's not able to go through a bypass surgery with angioplasty, and the beauty of it is that it can be done over and over. So, I always tell my patients, I don't need the vessel to stay open forever. I just need it to be open long enough to get the ulcer to heal. Once it's healed, then we just have to prevent you from having another event. So if we can just have it open up long enough, that's all we need for something to heal. After that, then we can, kind of watch it. So it's not necessary, if they don't have any event, there's no pathology in the foot, we're not going to do an angioplasty unless they have pathology, if there's a need for it. So clinically, I mean, obviously, absent pulses, claudication, dependent rubor, pallor on elevation, and atrophic integument. What's important there on the pallor on elevation, one of the things that we check, a lot of people think, oh, this patient's foot's infected. If you elevate the foot and the redness goes away, it's not really infection, it's ischemia. It's some kind of ischemic event. So we try to teach, the residents that come through here, they're like, oh my God, it's infected, it's red, but you have to, is it infection or is it ischemia? And you have to pick which it is. The easiest way is just to elevate that lower extremity and see if it becomes pallorous. And if it does, then we know that it's some kind of ischemic event. So how do we improve vascular status? Obviously, in controlling the edema, and like I mentioned, the angioplasty and bypass surgery. Controlling the edema, we use Una boots, and we use a lot of Una boots. It's simple to put on, it's simple to teach somebody to put on. At the same time, it's a dressing that they can keep on for a week and come back in a week, and they don't have to do any dressing changes. You don't need to do home health care or anything like that. You can do it in your office. Angioplasties, of course, I'm going in, and like I said, there's so many new technologies with there's Fox Hollow that actually scrapes off the plaque. There's angioplasties that actually balloons them. There's cryotherapy that actually freezes it. So there's tons of new techniques that they're, finally they've gotten the size small enough to get to those lower extremity vessels. And of course the bypass surgery, which is in some ways at some point was the gold standard. We don't see it as much, or at least I haven't seen it as much now that people are getting bypasses to the lurch, to the DP or PT pulses. When I was a resident, that was the thing. If you wanted something to heal in the foot, you needed to get a bypass, and a lot of vascular surgeons were not, once I got on the outside, they weren't prepared, they weren't able to do it. They were always doing other, it was only to the popliteal that they would do the bypass too. So now looking at the ulcer, what can we deem and learn from the ulcer to treat it? Now that we know all the things that can either prevent it from healing or assist it, whether it's improving the vascular, understanding what neuropathy, deformity. So we have to find out, well, where's the location, the size, the shape. What happened here?
It's quite out.
I'm looking at this one again. It looks great.
It's quite out, I think.
So,
So in the borders, are they irregular? Are they hyperkeratotic? Is there undermining, which means that the ulcer actually is larger than what you see? Is there infection? Is there cellulitis? Is there odor? Is there purulence? There's drainage? There's, not that you guys ever want to learn this, but after a while you kind of know the smell of what's, what kind of an infection it is. I mean, you know the smell of Pseudomonas. In school they taught us it smells like corn tortillas. And it does, unfortunately, and it makes you not want to eat corn tortillas, but that's what it does. And so there's certain odors, there's certain, the creamy white purulence, you're always thinking of Staph aureus. If it's clear and there's a lot of drainage, I'm already thinking of MRSA or Klebsiella. So there's a lot of little things like that you, if you do it long enough, you start picking them up. And the treatment is just dependent on the underlying medical condition of the patient, and then just the ulcer's history and what has been done for it. Has it been offloaded? Has it been debrided? What has been done previously as far as wound care? And treatment, like I said, is debridement is initially prevention and education. So here's the ulcer types. I mean, you have a necrotic wound, and you always want to remove all the necrosis and cleanse the wound. You have an infected, obviously you want to minimize the infection. There's tons of wound care products with silver, with Hydrofera now, there's a new one that's coming out. There's tons of products, and if you listen to the the reps, everyone's better than the last one that you were using. So I don't know, I couldn't tell you which one to pick. Drainage, but you want to prevent that. And then granular, how can you close a wound, whether it's a skin graft, whether it's synthetic graft like a dermagraft or Apligraft. Those are the things that you want to use or plan on. So right when you see the wound, we try, and I'm not saying we're all experts at it, once we see the wound, we have a plan of where it's going to be, what's our plan for closure. Are we going to, do we have to do something surgically to offload the area, or is it something that we're planning some kind of skin graft, whether do we need to send it to plastics to do that graft? Is it large enough, or is it something that we can do with the Apligraft or dermagraft?
The dermagrafts that you do, you can do those like at the bedside.
Yeah, even the Apligraft you can do at the bedside. Yeah, and which is nice. It makes it easier. A lot of people go to the OR, but you don't really need to. You just need we have a procedure room in our clinic, so we can do that. The biggest thing important of a wound is that you have to make a chronic wound acute. So every patient is going to freak out when you go in and debride a wound because it's bleeding, and you're like, that's good. We want it to bleed. We want to get all that necrotic tissue, make it nice and pink. We call it beefy red. So if we can get any wound to beefy red, that's ideal. So what other things do we have? Like I said, that we have Apligraft, we have dermagrafts, we have multiple enzymatic debriders. The one that I used to much enjoy, which is the Panafil enzymatic debrider. They took it off the market because people were getting allergies to it. So now Santil, we have Santil here in the hospital. We use that as an enzymatic debreeder. Collagenase, there's tons of enzymatic. Obviously, the gold standard is just surgical debridement. It's just the easiest. But there's going to be there's certain patients that are vascularly compromised that you don't want to be too aggressive with. And prevention of foot ulcers, and this is where, from our standpoint, this is where we need you guys to keep those patients in the best medical position possible, as so they tight glucose control, good high blood pressure, and then we'll get them into the appropriate shoe gear. We have some pretty good shoes here in the hospital that we can get for all our diabetic patients. We also get them into some diabetic socks, which have copper in them that kind of helps with discoloration, and they're actually very good. But big thing is educate and teach. So there's always that wound that just doesn't heal, so and you've done everything, you've gone through the steps, everything's been appropriate. So this is when, and these are pretty much zebras. I wouldn't say that this happens very often, but they do happen, and this is when you start going after 30 to 60 days, you're like, okay, well, it's not getting any better. What's going on? What do I need to look for? And these are just some of the, malignancies that you might find from an ulcer that you're just assuming that it's just your typical neuropathic superficial ulcer that just doesn't heal. And it's there. I won't say that I've had a lot of them. I haven't had any when I've been out in practice, knock on wood, but it's there, and you have to start thinking about that. So you can't just assume, okay, well, I've been treating this wound for 30 days, it hasn't been approved. Then that's when you start thinking, okay, well, there's something else. I need to do a biopsy. I need to start looking somewhere else. Understand that every wound is in some kind of evolution, whether it's deteriorating, improving. You have to kind of understand where it's at in that evolution of whether it's starting to heal or not. That would help you in treating the patient.
Is that you?
That's my little son that looks just like me, but
He does, doesn't he? What's his name?
Zane. So
How old is he now?
how old? He's 15 months.
Oh, he's adorable.
He's in his swim grade right after swimming.
Aw.
Any questions? That was easy.
Wow, that was great. We really appreciate this.
Oh, no problem.
And I'd like to present you with the M&M Award. And they're with peanuts because I know you haven't had lunch.
Thank you.
So you need the protein too.
Appreciate it.
Has everybody filled out a participant? If you don't mind, yeah. Anybody else? Where have I missed one here? Have you filled one out before?